Assalamu alaikum. Today we are discussing a case of left non-functioning kidney secondary to stone disease, which had multiple episodes of pyelonephritis. So the purpose of sharing this video is actually the fact that such kind of kidney is really stuck here and there with the surrounding structures, and its architecture is quite hard, and it's not easy to dissect it. So I thought that this might be helpful to share this video and see how are the structures around. Especially dealing with the pedicle is quite difficult in such cases. So it requires a lot of patience, and you should take your time and do the dissection properly, bit by bit, and only then it is possible to be successful in such cases. So I started this video right from the beginning, mobilizing the colon medially. You can see that lower down where there is no kidney, the tissues are quite good. The tissue planes are quite discernible, and one can easily dissect the colon away from the kidney. But where there is kidney and there are signs of inflammation, it is really badly stuck, and mobilizing this kidney leads to little redness of the field, which can hamper the dissection and the vision. So here our main purpose is to dissect the spleen as up as possible, so that we can have a good exposure, because in such cases, if the exposure is not good, one can injure the structures surrounding the kidney. We saw the edge of the liver above the spleen, so the liver is quite big as well, and the inflammation is reaching up to the upper pole and the adrenal, and you can see that here mobilization of the spleen is very difficult. All the tissues are inflamed and badly stuck. So there are chances of two kinds of complications. Number one is the injury of the diaphragm. So if you go too far away from the kidney, you can open up the diaphragm, and if you try to stay away from the diaphragm, then there are chances that the splenic hilum or the splenic vein especially, and the splenic artery may be injured, and that may lead to a serious complication, which can end up in splenectomy. So managing the diaphragm injury can be done laparoscopically. We can repair the diaphragm at the end of the procedure by repairing it with the Prulene one and having a chest tube inside, and that the chest tube can be removed on the first or the second post-op day. However, management of the splenic injuries or the splenic vascular injuries can lead to a loss of spleen, and that too, splenectomy will not be that easy. So care must be taken, and dissection must be performed bit by bit. Here you can see that we have mobilized the upper portion quite a bit, and now after mobilizing a little bit of the upper pole, we are coming lower down. We are trying to identify the ureter in the area where there is not much inflammation. However, as I said that there were many episodes of pyelonephritis, so the kidney is chronically pyelonephritic. So pyelonephritic means that the ureter will also be inflamed, and the structures around the ureter will be stuck to the ureter as well. So here care must be taken not to injure the bowel, not to injure any mesenteric vessels, and especially lower down, not to injure the common iliac artery. So identification of ureter and the gonadal vein would be of utmost importance here. Once we have mobilized the colon enough, then we go up again and see if we can continue with the dissection. However, threshold here for conversion should be kept low, because it is always safe to open up the patient rather than to complicate the patient. And the indications for the conversion would be if there is no progress in the dissection for around half an hour, I think it's fair enough to convert the case. Or if you think that there is a highly likely chance of injuring any surrounding structures. We discussed the common iliac artery, the colon, the diaphragm, and the hilum of the spleen, But another important thing on the left side is the tail of the pancreas. So the tail of the pancreas is also very closely attached and adherent in this case to the kidney. So any signs or any doubts regarding the pancreatic tail has to be clarified. Once we are sure enough that we have dissected and identified the ureter, here you can see that we have identified a tubular structure which is taken for a ureter. So after doing this, we'll place another port. Here we have placed a needle and decompressed the kidney. And then we have placed another port to lift up the lower pole for us. And then we have progressed along the anterior surface of the kidney. And now we are concentrating on the hilum of the kidney. Although the structures are not very easily identifiable, however, we can see that the tail of the pancreas has been lifted up off the renal hilum. So we are now trying to identify the renal vein. Here, in the horizontal line, one can easily identify the gonadal vein. So we are dissecting lateral to the gonadal vein, which means we are safe enough. If we are dissecting medial to the gonadal vein, there are two kinds of dangers. Number one is the injury to the lumbar vein. Second is the injury to the superior mesenteric artery. And third is the injury, of course, to the surface of the aorta. So the renal vein here is now identified. Once the renal vein is identified, then is the turn to find out the renal artery. Once the renal artery is identified and dissected enough, we will place a clip on the artery. So a lot of inflammatory fibers here, and according to the study of the CT, the artery was located inferior to the vein in a very typical position. So we were lucky here that the artery was not behind and superior to the vein. Although there has been a lot of inflammation, the hilum has been kind enough to be in a typical position. So you can see here the artery. Once the artery is clipped, our confidence will be boosted, and we'll feel more relaxed. The anxiety will be decreased. So we'll be able to deal with the hilum in a more confident fashion. So here you can see we have clipped the the artery. Now we are dissecting the vein. It must be noted here that in such kind of kidneys where there is a lot of inflammation, and the kidney is chronically inflamed and fibrotic and non-functioning, the hilum is usually smaller, the vein is usually thinner and smaller, so it can be dealt with easily. Here you can see the horizontal gonadal vein. So we will be dissecting the renal vein lateral to this gonadal vein, and as close to the kidney as possible to avoid any injury to the structures which are located medial to this position. So the structures around and the tissue around the vein is being mobilized and dissected and divided. And after doing this dissection, we'll be using our favorite instrument, the 10 millimeter right angle, to dissect behind the renal vein. Once that is done, we'll be able to clip and divide the renal vein, and then of course we will go back to the renal artery to dissect it more, apply more clips, and then divide the artery. And hence, after doing the hilum, we'll be doing the rest of the dissection, mobilizing the kidney from the lateral aspect, the posterior aspect, superior pole, and then dividing the ureter, and hence the nephrectomy will be completed. So here you can see that we have applied a lot of clips. One more clip, of course, medially will be really helpful and will be very much safe. We applied this clip because the second clip was very much near to the edge. And now dissecting the artery further. So further dissection of the artery helps us apply more clips. So we quickly apply clips and then divide the artery, because there is pooling of blood, maybe there is congestion of some tissue, and then we use the suction to clean up the area and do the bipolar to do the coagulation and make the area clean. And now again, after doing the hilum, we dissect the kidney. So, and we are moving more towards the kidney rather than medially, because this pancreatic tail may be injured. So here you can see that adrenal gland is also very badly stuck to the upper pole of the kidney, and during the process we have opened up the adrenal gland as well. However, it was inevitable because it is good that the pancreatic tail is saved. Here again, one has to be really careful and has to be really on the kidney rather than on the diaphragm, because this area is so stuck to the kidney that dissection away from the kidney may lead to injury of the diaphragm. So that was the main purpose of sharing this video, to number one, show the beginners and the trainees and the young laparoscopic surgeons that difficult cases can also be performed laparoscopically. However, these are the things that one has to Keep in mind the diaphragm, the spleen, the tail of the pancreas, and those should be kept in mind. Once you have those things in mind, one can really save them. So here the diaphragm needs to be saved. This area is really badly stuck to the kidney. So if we go a little lateral or away from the kidney, the diaphragm fibers may easily be opened. So once there is chance of this, we pull the kidney medially and we dissect as close to the kidney as possible, and hence the injury is prevented. So the kidney is then mobilized and we will clean the area and then place a drain. Thank you very much for watching.